Interestingly, and actually very disappointingly, and I hope this will change, for both Lyfgenia and Casgevy, they asked whether fertility preservation could be included as part of the reimbursable process once the drug is approved. And they've been denied. They were denied because...
Hey, Sickle family. I'm Wunmi Bakare.
I'm Christelle Salomon.
With a special guest appearance from Dima Hendricks.
And we would like to welcome you to the Through the Genes podcast,
where we talk about living,
healing,
recovering,
and exploring transformative therapies for sickle cell disease.
We will also talk about our individual journeys and the bond that we have built as sickle cell sisters. Hey, Sickle family. Welcome back to season 2 of the Through the Genes podcast, where we have real, unfiltered conversations about sickle cell disease, advocacy, and cutting-edge treatments. I'm one of your hosts, Wunmi Bakare, and I have my fantastic co-host and sickle sister,
Christelle Salomon here. Hey, Sickle fam.
Now, today we're diving into what happens to the body as it goes through gene therapy. As I'm sure many of you will remember, in December of 2023, the FDA approved 2 gene therapy treatments for sickle cell disease. And that was a period of celebration for everyone involved, all of the key stakeholders within the sickle cell space. Today, we're going to learn more from a physician scientist who is a leader in the field of gene editing. I would like to welcome our guest today, Dr. Matt Porteous, who is the co-founder of Kamau Therapeutics. He graduated from Harvard University, completed his MD and PhD at Stanford, and also did his residency training in pediatrics at Boston Children's Hospital with a fellowship training in pediatric hematology and oncology at Boston Children's Hospital and the Dana-Farber Cancer Institute. When I say he has a robust resume in every sense of the word, Dr. Mark Porteous, welcome to our little show Through the Genes.
Hey.
Welcome.
Thank you so much for inviting me and being on this, first episode of season 2. It's a real honor for me to be thought of, and really exciting for me to be able to talk to you both about really important issues for the community, and how we can make this process of gene therapy safer, more effective, more accessible, more understandable, all those things that you guys have been putting in so much time and effort around.
Welcome. I had the pleasure of meeting him in person in February, and he's one of those people that is powerful, but also graceful. They're not intimidating. They don't take themselves too seriously, incredibly approachable. And I respect that, because oftentimes we meet providers who there feels like a bit of a disconnect between that patient-provider relationship. And Dr. Porteous is none of those things. Now, to start us off, I would like us to go back to the very beginning, because you've been in this space for quite a while. Can you give us a brief history lesson about gene therapy? When was it developed and how was it developed?
Yeah, we could talk the whole hour about just that question. But, I think a brief summary is, I think you've gone through the basis of sickle cell disease, that it's an inherited disease and in one gene. And so on paper, the idea of gene therapy, whether adding a new gene to compensate for the mutated gene, or actually directly modifying the genome to either correct the mutation or compensate for the mutation, is something that was described almost 40 years ago as the concept of gene therapy was being considered. But taking an idea on paper or in conversation and then converting it into the approvals that you just described in December of 2023, it's taken several decades. And we tried something, we figured out this worked okay, but this didn't work as well as we hoped. You go back, you improve things, and then you come back and try again. You hope to do it in a very transparent way, but that's the way novel therapies get developed.
We know we could spend so long on this, and we've asked you to condense such a big history in such a short period of time. So thank you for giving us that context in terms of how long we've been looking into this. It's not like, oh, Casgevy was approved last year and people had just started working on it. This has been such a long process. And I think getting an understanding of how long it's been in the works is actually helpful for warriors because it gives us context. Like, this isn't just something someone was curious about 3 years ago and now they're trying it out. Like, this has been years of research and tweaking and asking so many different questions to better understand how this would work practically, but also how it would impact our lives.
Yeah.
And so I appreciate that context. And so we know gene therapy is such a large term now to describe so many different therapeutic options, more than just sickle cell disease. But for sickle cell specifically, we've got Casgevy, we've got Lyfgenia. There are so many clinical trials, different investigational gene therapy options, and they all work slightly differently. They're not targeting the same exact thing. Can you help us understand how to break down the different therapies and what makes each of them unique?
Yeah, thank you. Great question. People can divide them into different ways, but I'm going to divide them into 3 buckets. The first bucket is to use a virus to insert a new copy of the gene into the stem cells that will make red blood cells. And that is the fundamental process of Lyfgenia. And what will happen is the virus inserts itself. It has a part of the virus that tells the cell when to turn a gene on. And then the gene itself is a version of our natural hemoglobin A gene. It's actually not exactly the hemoglobin A gene. It has a couple tweaks in it that makes it more potent at counteracting sickle cell disease. So now what the stem cell has is a S gene and an S gene, because you need 2 S genes for sickle cell anemia, and a new A gene. And the new A gene competes with the 2 S genes. And that works. That's Lyfgenia. Now, in the first approach, this viral approach, the new gene can go different places in the genome. There are concerns that sometimes the gene can land in the wrong place that might cause a problem. That hasn't happened in sickle cell disease, but it has happened in other gene therapies. And so we're very careful about how to design the virus to prevent that from happening. The second bucket is to use genome editing to turn back on fetal hemoglobin. Sorry, I haven't had a chance to listen to all your prior podcasts, but you may have gone through that when somebody is born with sickle cell disease, they don't have very many symptoms for the first 6 months to year of life because they have fetal hemoglobin in their blood, and that counteracts sickle cell disease. We also know from people with sickle cell disease that if somebody naturally has higher levels of fetal hemoglobin, they tend to have a less severe disease. They don't not have the disease, they just tend to be a little less severe. And then finally, hydroxyurea, which is now a approved, drug therapy for sickle cell disease. One of the major ways it works is to turn up that fetal hemoglobin a little bit. In some people, it turns up a lot and it's really effective. And in other people, it only turns up a little bit and it's not as effective as we'd want. And even the same person who might have been very effective when they were a 12-year-old, it can become less effective when they're a 25 or 30-year-old. And it has side effects and it needs to be carefully monitored, and anybody on it should be have close relationship with their physician. But it's a very good drug. But the idea is can we use genome editing to replace hydroxyurea, but create that same effect of turning up fetal hemoglobin to counteract the sickle hemoglobin? And that's how Casgevy works. It uses genome editing. Okay, so we're going to get a little complicated here. Normally, a protein called BCL11A gets turned on after birth, and the protein comes and binds the fetal hemoglobin gene and keeps it suppressed. So we have a repressor or an inhibitor of fetal hemoglobin. And the way Casgevy works is it edits the BCL11A gene so it no longer gets turned on. And now you inhibit the inhibitor, or you block the blocker, and that allows fetal hemoglobin to come back up. And in Casgevy, you get enough fetal hemoglobin turned back on that it counteracts the sickle hemoglobin, and patients now can go live a really great life. Their amount of pain episodes almost disappears completely. Again, there's variability. Not everyone, fortunately, we're very different. Humans are diverse people, so not everyone responds the same. But in general, the results look excellent and the safety looks excellent. And that is why it was approved by the FDA in December of 2023 and has been approved in Europe and other countries as well, right around the same time. Now, those are the two approved therapies. Still in clinical trials and development is the BCL11A protein binds to the DNA in the gamma globin, the fetal hemoglobin gene. That's how it suppresses it. So another way of upregulating fetal hemoglobin is if you change the binding site. So it no longer has a place to bind, no longer has a home to bind to. And so the BEAM trial, which is now, I think, fully enrolled, and we're excited to see the full results, actually didn't work by trying to inactivate BCL11A. It just it inactivated the binding sites. And again, we're seeing really not in the few patients they've reported publicly, we're seeing that the fetal hemoglobin is actually even increasing maybe even more than in Casgevy, which is very interesting. So that's the second bucket. Can we turn fetal hemoglobin on? The third bucket is in clinical trials, and Christelle knows this approach very well, as do I, because this is what Kamau does, is can we use genome editing not as a workaround to turn up fetal hemoglobin, but can we use genome editing as it implies? Like, can we use it to change a single letter in our genome? And for sickle cell disease, that would be to change the single letter that causes sickle hemoglobin back to the letter that causes hemoglobin A. Kamau Therapeutics is sponsoring a trial where we do that in one way, and then UCSF, UCLA, IGI has a clinical trial in which I hate to use the word correcting because it makes it sound like the sickle cell mutation needs to be corrected, and we can go into that, but changed back to the hemoglobin A. And the reason I'm reluctant to say correcting is, as you probably all have talked about, when you have one copy of the sickle cell gene and one copy of the A gene, and you live in some place where there's lots of malaria, you're actually in better shape than if you have two copies of the A gene. You're less likely to get severe malaria. So we don't want to think about this sickle gene as being all bad. It's actually good in some circumstances, but when you have two copies of it, then it's bad.
That was such a great explanation because it helped me understand what bucket they all are in. I didn't realize that Lyfgenia was one bucket, Casgevy and the BEAM trial focus more on the fetal hemoglobin.
Yeah.
Then the last is Kamau. So it helps us, it puts things, at least for me as someone who's like a science buff and also incredibly curious, it helps to simplify and better understand each of these gene therapy treatments that are available for patients, whether in clinical trial or approval by FDA. Now, I want to move on to kind of the pre-treatment and conditioning. What happens before your day 0? Now, we know that, Christelle and I know this from personal experience of being transplant recipients, that during that pre-treatment and conditioning phase, they stop the use of hydroxyurea.
Yep.
Which, as we know, is the standard of care treatment for sickle cell disease. And when they stop that, instead, they manage the patient's hemoglobin level with red cell exchanges. Now, can you help us understand what happens to the bone marrow when they stop the hydroxyurea and they start the red cell transfusions?
Yeah, that's fantastic question. So in order for gene therapy to work, as we talked about, we need to harvest the blood stem cells, hematopoietic stem cells. And we want those to be in high number and to be as healthy as possible. And actually, there's studies about what we mean by healthy. We know that hydroxyurea one of the ways it turns up fetal hemoglobin is it kind of causes some stress in the marrow. That the stem cells kind of turn on fetal hemoglobin in response to being stressed, a little stressed. And if you put cells in culture like in a tissue culture, in a dish, and grow them in the lab, and you expose them to hydroxyurea, they don't divide as fast as they should. So one of the reasons we want to stop hydroxyurea before we harvest the stem cells is because we want the stem cells to be as healthy as possible and as numerous as possible. The more you get in general, the better you do. Okay, but wait a second. I'm on hydroxyurea because if I'm not on hydroxyurea, I'm going to have pain. So how do we replace that? So one is we want to replace the therapy with something that will prevent pain. The second thing is we want to settle down the marrow. So another sort of biology of sickle cell disease is sickle cell disease, even though it's a disease of red blood cells, the sickling and the hemolysis and the anemia can cause inflammation, can cause everything to be inflamed. And again, we know that stem cells won't be as high in number and they won't be as healthy if they're in an inflamed environment. So how can we both help a person not have a pain crisis and settle down the inflammation? Well, the way we do that, and again, full credit to investigators at different places, but also Bluebird Bio for identifying that if you put somebody on 3 months of exchange transfusions, so they come in every 4 weeks, they have several liters of their blood removed and replaced with several liters of blood that doesn't have sickle cell disease, that can keep the pain crisis down. In fact, we take a side version, and it can also decrease the inflammation. What you may know is that some people with sickle cell disease, instead of having pain, can have strokes, or what we call silent strokes as well. And one of the standard therapies for strokes and silent strokes is exchange transfusion, because it is the best way of preventing a stroke from happening, better even than hydroxyurea. Okay, so now somebody has to go through 3 months of coming into their center every 4 weeks and getting this exchange transfusion. And then we have to harvest the stem cells. And I talked about how before the way it used to be done would be to put somebody, give somebody anesthesia, have them come to the operating room and stick a needle in their hip bone, to both sides of their hip bones multiple times. And honestly, people do recover from that. I've done it and it's painful, but they do well. But now we have this mobilization and pheresis step. And so they get a drug called plerixafor, which sort of stimulates the stem cells to come out of the marrow into the blood, like I described before. And then we can hook, and that drug acts for about 2 to 12 hours. And so that's why when people would get the plerixafor a few hours before, they get hooked up to the pheresis machine. They're on the pheresis machine for multiple hours, depending on their blood counts and how they're doing. And then you count the number of cells, and then they might have to go through that until you get enough cells that we think is ready to make the gene therapy product. Okay, so now the cells get shipped to a place where the gene therapy is made, what we call manufacturing. Kind of weird. It's not manufacturing an automobile. It's manufacturing a autologous. That means the patient's own hematopoietic blood stem cells with the gene therapy. The process itself takes about a little under a week, 3 to 5 days. And it's done in a special facility. Everyone who goes into the room with the cells is, in these white bunny suits. I don't know if you've seen pictures, and it's every step, there's a person who does the step, and there's a person who monitors the step, and there's a third person who oversees. So it's a very carefully done process. You follow a protocol that is, you turn the centrifuge up to this, you add exactly 1 ml of that at this time. So it's a very regimented process. And at the end of the process, the cells then have to go through a series of tests, what we call quality control. Did they get contaminated? Because we're doing this in, a very clean facility, but there's always a risk. Did the gene therapy, gene editing work? Did we get the changes at a level that we know are needed? Did we see anything that we didn't want to see that might be concerning? And that testing can take, anywhere between 1 month and 4 months. And it is only after that testing is completed that the manufacturing site will send to the sponsor, the person running the study, that yes, these cells pass and they are now ready to be infused into the patient. So now the treating physician and the patient now have to come together and say, okay, are you ready to get your cells? And it'd be great if we could just infuse the cells without having to do anything. The problem is that the stem cells fully occupy the bone marrow. So there's no space for the new cells to go into. So that we could infuse the cells and there would be no space and they would just die before they took up home in the bone marrow. So that's where we have to give chemotherapy. What we use is busulfan. But luckily, in an autologous transplant, when we're in the patients using their own cells, we only have to use busulfan. We don't have to use other chemotherapy, a bone marrow transplant where you're using someone else's cells. So then the patient comes in and gets four days, usually 4 days of busulfan, occasionally 1 day, but we think 4 days is probably a better way of doing it. The levels of busulfan are monitored so that we make sure that we don't go too high, because then you can have problems in the liver or in other organs. And we don't go too low, because who wants to go through this therapy and not have it be effective? So we measure that the busulfan levels hits the sweet spot. And that's why some people they'll get a dose for the first couple of days, and then the last couple of days, the dose will change, because we adjust the dose to hit that level based on that person. And at the end of the 4 days, we give then a day to let the busulfan wash away, because we don't want any busulfan in the body when we give the new gene therapy cells. And then those are infused through an IV. Preserve the cells from dying during the freezing process. We mix them with something called DMSO. It's a chemical that prevents the cells from blowing up when you freeze and thaw them. And so when we infuse the cells, they're infused with DMSO. So they're thawed at the bedside, and then they're infused directly into the person. About 50% of people can smell DMSO, and it has a very distinctive odor and it's fine. And some people can't smell it and other people can. I can smell it, but, and it's fine. And it lasts for several hours as the DMSO kind of has to be, secreted from the person. So then we wait, because the chemotherapy has destroyed the resident stem cells in the bone marrow. We've infused new stem cells to replace them, but it takes some time for them to set up shop and start making blood cells. In the meantime, the chemotherapy can damage the lining of the mouth and the lining of the intestines, and so you get mucositis. The blood counts are low because the bone marrow is not making any blood right now. And so you can get fevers, which need to be treated with antibiotics. You can get low blood counts and you need a red blood cell transfusion, or low platelet counts, which can cause bleeding. So you can get a platelet transfusion. And so then there's, a couple to several weeks of waiting while that new gene therapy product takes up shop and starts making first the white blood cells to help protect you against infection, and then red blood cells and platelets. And the timing of when that exactly occurs is variable between different patients. What's interesting, I'll stop, is that the white blood cells, you can almost tell when the white blood cells are starting to come in, because what they'll tell you the day before you see white blood cells on a blood test. So we do blood counts basically every day to look for how the blood cells are doing. And before you even see white blood cells on the blood test, the person will often say, my mouth is feeling a little bit better. I don't know why. And it turns out the white blood cells, as they start to come in, kind of help the healing of the mucositis. Not always, but it's a subtle sign that sometimes you pick up on. And then the next day you'll see, oh, look at that. We can see, instead of the count being 0, it's now 100 or it's 50. And then you'll slowly see the neutrophil count start coming up and up. Wow, that was long. Sorry. Hopefully it was useful.
Now, what are some of the follow-up tests that patients will require just to make sure that, again, things are working the way they are supposed to?
Yeah. So that's exactly right. Because this is a new therapy and we don't know, okay, it looks good in the first 2 years. That doesn't mean, what's going to happen in 5 years or 10 years or 15 years. Honestly, what's going to happen in 35 years or 55 years. So we want to keep monitoring people. Now, immediately after the gene therapy, the frequency of monitoring can be, quite very, very frequent. Can be sometimes once a week, then to once every 2 weeks, then to once a month, to once every 3 months. And, it spreads out. After about the 2 to 3 year mark, the monitoring can spread out to once every 6 months or eventually to once a year until you've reached 15 years. Now, I think in all honesty, everyone's going to be followed if they're willing for the rest of their life, right? So what happens, there's no set of tests that are mandated by the FDA for those annual long-term follow-up visits. So we're going to learn if something turns up, then we might say, okay, you need to test for this. But right now, what that generally is a check-in. How you doing? How's your pain? How's your life? The general, just check in, how you're doing. And then there will be, a check of your blood counts. How do they look? Check on the types of hemoglobin you have, the hemoglobin electrophoresis. Check on your liver tests. Check on some, you'll check usually some thyroid tests and some endocrine tests. And, particularly if you're thinking about fertility issues, you may get some blood tests around fertility. But there's no sort of mandated menu of things.
It's always great I'm so excited to talk to you because I know you're on the cutting edge of everything. And so hearing you talk about this stuff makes me very excited.
Yeah.
But I won't go down that rabbit hole. As we wrap up, I want to ask you a two-part question that I think is going to be super impactful as we close this conversation. So one is for patients considering gene therapy, what do you wish more of them knew before starting the process? And then the second part, are there any misconceptions that you would like to correct on this show before we head off?
Those are both good questions. I'm pausing because I don't have immediate answers. I do think that in terms of what I don't want to say wish they knew, but I think it would be helpful now that enough people have gone through both allogeneic bone marrow transplants and gene therapies. And I think there are stories out there, there's lots of educational materials out there, is to go find those and read them so that when you come to your doctor and talk to your family about what the right choice for you is, you're not just getting one perspective. You're hearing from different perspectives. We all know that, Dr. Facebook is awful, and Dr. Google is a little bit better, but there are rabbit holes you can go down. So I would also caution about really reading anything that's not from a really reputable source. Your podcast, Vince Bonham's work at the NIH, Sickle Cell Disease Association of America, really some of the local disease-specific associations. The American Society of Hematology has put out a lot of great educational materials. Now, I don't want to say it's mandated because honestly, a warrior is a warrior and they are doing what works best for them. And the last thing I would want to do is impose additional work for them. But I think that can be helpful just to educate themselves. Misperceptions, again, I think it's not so much misperceptions, but really listening to people's stories and understanding, we're in an age of misinformation and disinformation. It's not specific to this. Just being really cautious about where you're getting your information from.
I can appreciate that answer because digital media, right? We love it. We
Yeah.
hate it. It can be beneficial in terms of getting information out publicly within a short amount of time.
Yeah.
But it can also be lethal because certain people feel like they're an authority or they
Yeah.
have some privy of knowledge that isn't necessarily backed by science. And on this show, I think that's one of the things that we pride ourselves on, is really sharing with the community the scientific research that goes behind these novel treatments, because we don't want to purport misinformation. Neither do we want to overwhelm an already overwhelmed community. But now I want us to transition to my favorite segment of the show. Dr. Porteous, we cannot thank you enough for the clarity that you have offered on what happens to the body as it goes through gene therapy. I feel like I've been educated to a point now where, in conversation with other warriors who have been through that process, I'm now aligned in better understanding what their body went through. But let's move to our rapid fire round, which is where we ask you questions because the community knows you as Dr. Porteous. And these questions give us an opportunity to see Matt.
Okay.
Individual behind greatness. And Christelle and I are very generous people. So we're going to give you 2 seconds. We would have done one, but because we're just so kind, we're giving you 2 seconds.
2 seconds. Okay.
Think you cannot pause. It has to be the first thing that comes in your mind. Are you ready?
All right. Yep.
Okay, great. If you could time travel, would you go to the past or would you go to the future?
I would go to the past.
Wow. Can I ask why?
Well, because I would do things differently. You know, I'd make better decisions.
Okay. But would you be where you are now?
I don't know. That's always that is the $64 billion question.
Ooh, that was a good question and a good answer. Oh man, that was so good. Okay, moving on to the next. What's one simple health tip everyone should know, but most people ignore?
Well, I think everyone knows it. I think a little bit of exercise every day is really important. It's important for your physical health. It's important for your mental health. It's important, I think, for longevity and aging and keeping your organs healthy. It does not have to be 2 hours. You know, you don't have to train for a marathon. You know, half an hour of exercise several times a week is incredibly important. Moving your body.
I appreciate that. Recently, I've been having like subtle neon signs in my life of like, girl, you need to start working out.
Yeah.
And then I decided to do yoga on Saturday. And then yesterday, my body was like, girl, don't do that. Pace us next time.
Hey, what I would suggest is people listen to Beyond the Genes podcast as they're walking their neighborhood. Perfect hour use of their time, right?
That's a great suggestion.
Now, if you could have dinner with any historical figure, living or dead, who would it be?
Oh man, I don't. I'm gonna have to say I don't know because you're asking me in No, you're saying in 2 seconds. I mean, this is something that I would have to take some time to think through. Okay, here's what I'm gonna say.
Okay.
You have to invite me back for the next round. I'll have a better answer.
There we go. I like the way you think. I was like, this is, I see. Man, okay, hopefully, I think you'll have an answer to this one. Okay, what's one thing that makes you smile no matter how bad the day is?
My dog.
Oh,
my dog. Dogs are, they don't care how your day is. They're just happy to see you.
They're just happy to see you.
Yeah.
Okay. Final question. You're doing good, Dr. Porteous. You're doing really good. If you were an element on the periodic table, what element would you be and why?
Let's see. I don't know why. Helium. Oh. I don't know why though. Just seems like a good element to be.
It's fun and it makes your voice sound
like this. Light and airy, I guess.
Light and airy. I love that. Dr. Porteous, this conversation has been everything. It's been real, it's been informative, but more importantly, it's been necessary. If there's one thing I hope our listeners take away with them, it's that every patient is uniquely different. So every journey is also uniquely different. Educate yourself, inform yourself, recognize that if this is the path you are considering, your experience might differ from someone else's. But our hope is that you will come out on the other side with an improved quality of life, with a new zest to experiencing things you never could before. And I'm excited to see that science is pushing the boundaries of what we ever thought was possible for sickle cell disease.
Thank you. If I could add one thing to that, which is that since every journey is different and every person is different, everyone needs a support network. But don't feel like your support network has to be identical to someone else's.
Mm-hmm.
You know, if you want to have a small group of confidants and that's your support network, great. If you want to create a large community around you, that's great too. But make sure you have a support network and make sure it is aligned with yourself.
That's so good. And if I can add a few more thoughts, Dr. Porteous, thank you so much for joining us. And I'll share a personal tidbit. I remember when I was in college and doing research in a lab, and I was like, I want to do sickle cell research. I remember like looking up sickle cell research and your name being like one of the first names I ever saw. And that was when I first got open to the idea of transplant gene therapy. And I was like, wow, this guy's doing amazing stuff. And so it's just such an honor to have you on the podcast, to talk to you in the flesh, and to see how your passion for sickle cell and transformative therapies has just only grown, and how we're able to reap the benefits of your hard work over all these years. So I just appreciate that you took the time to be on here, and thank you for demystifying and making us there's not like equal players, putting us on a level field, putting patients on a level playing field where they feel like they're empowered to really make informed decisions. So I appreciate you so much, and this has been awesome.
Well, thank you for those very kind words. But again, I'm going to say this is not a sport of one. This is a team and community-based effort. And without everyone involved bringing their passion and expertise and their perspective, no one would be successful here. So yes, I'm proud of my commitment to this community and to the warriors with sickle cell disease. But no way does this happen without an incredible team around me in my lab, in my company, but also the broader community as well. So thank you all for being so engaged and open to conversation as well.
Amen to that.
Yeah.
Well, make sure you don't forget to listen to the rest of our episodes if you miss any. Wherever you listen to audiovisual content, that is where we will be. YouTube, Spotify, Apple Music, Audible, you name it, we're there. So we can't wait to see you on the next episode. Don't miss out. It's going to be good.
Until next time. This show is brought to you by Beam Therapeutics, Synthago, and Kamau Therapeutics, with support from the UCSF Sickle Cell Center of Excellence, Through the Pain Inc., and Sickle Cell Prodigy.